Good morning, everybody. And I hope you had a restful evening. And we had a great day yesterday, a great set of talks and very fruitful discussion. We have more of that today, an exciting set of speakers and a panel later on that would round it all off. This morning we are delighted to start off with a special lecture by Josh Salomon. And I'll just say a couple of words about Josh. I've known Josh for a few years now. Josh is a professor of global health at the Department of Global Health and Population at the Harvard School of Public Health. And he has been a pioneer in the development of methods and application of those methods to data gathering and analysis pertaining to population health. A lot of his work has been around sort of quantifying the burden of disease and mortality using a variety of new methods that he has helped develop, and also using methods to evaluate programs and policies in global health broadly. His whole set of efforts of methods and data gathering has also been important in priority setting in a number of ventures around global health. And he's the best person to tackle the topic for today's lecture, priority setting around HIV and TB. So welcome, Josh.
Well, thank you very much, Wafai, for a kind introduction, and thank you to the organizers for inviting me. It's really a pleasure for me to be here with you today. And looking at the agenda for the rest of the day, I can see that there are some wonderful talks coming up about specific priorities, and I really look forward to learning much more in those. What I'm going to talk about here is more about priority setting and how we think on a broad canvas strategically about what might be some priorities. And so I'm actually going to start today with an example that I think may be familiar to many of you, which was an effort called Rethink HIV that was undertaken a few years ago under the tagline that you can see here in the reproduction of the book, which is to try to identify smarter ways to invest in ending HIV in sub-Saharan Africa. And so the basic idea of this enterprise was to enlist a range of researchers to examine competing HIV/AIDS interventions based on looking at their costs and their benefits in order to help policymakers and donors prioritize investments and identify those with the highest payoffs. And so the prompt for the exercise was this question: if we successfully raised an additional $10 billion over the next 5 years to combat HIV/AIDS in sub-Saharan Africa, how could it best be spent? And so the exercise commissioned a panel of distinguished economic experts, including, you can see here, the Vice Chancellor of the University of Ghana and several Nobel laureates in economics. And they were asked to consider papers that were produced by researchers around 18 different proposals. And the panel invited the researchers to come present these proposals. They deliberated about them and came up with a consensus ranking of priorities to answer this question. And here's what they look like. So the first 5 ranked investments the expert panel deemed as excellent investments with a, quote, compelling need for urgent investment. There was a set of middle-ranked investments that were regarded as good, where there's a reasonable or a strong case for investment. And then there were a set of bottom-ranked investments out of the 18 that were labeled as poor, meaning that the expert panel did not see a strong case for these and did not endorse them for funding. Now, there's a lot, I think, that you could say about these rankings and about this process, but I'm going to resist the temptation to do that this morning, and instead I just want to take a minute to draw out some of the key points that I think are relevant to the talk this morning. One is that you can find on this list of priorities both examples of investing in R&D for new technologies And specifically, the panel recommended a doubling down on investments for vaccines as the top priority. And as well, a larger number of examples of investing in scaling up currently available interventions. Now, for a number of reasons, comparing these different types of investments is difficult. The timing varies, obviously. There are many sources of uncertainty about what the world might look like by the time, say, a vaccine comes along, and the fact that current healthcare and R&D are funded from different sources and so on. But on the other hand, it's true that on some level we do have to make allocation decisions that balance short-term and long-term goals. Now, the second point I want to draw out with this example is that a number of the top priorities relate to scaling up coverage of interventions like male circumcision, PMT-CT, ART, while many of the lowest ranked options relate to what are called health systems interventions, for example, relating to workforce or incentives to get tested, which you might argue, and I would tend to agree, could be rather important or even essential elements of successful scale-up. So this is a point I'll come back to in a little bit, but I want to flag that for now and move on. All right, so with that as a prelude, what I'd like to do over the next 20 minutes or so is to talk more generally about priority setting in TB and HIV. And I'll organize these thoughts broadly around the distinction between priority setting for research investments versus priority setting for healthcare interventions and strategies. And along the way, I'll mention some examples of priorities that have been identified for TB, HIV. I'll talk a little bit about frameworks for thinking systematically about setting priorities. And then I'll actually spend most of the time talking more specifically about one type of evidence that goes into priority setting, which is evidence on cost effectiveness. In particular, I'll try to describe some of the uses and limitations of cost effectiveness in global health in general and in TB and HIV in particular. And then I'll describe what I see as some key components of an agenda to make cost effectiveness more useful for global health policy. So let me start with this topic of priority setting for research investments. And in the area of TB HIV, there have been two efforts that have been led by WHO and Stop TB to define research priorities for TB HIV. In 2005, an expert working group was convened and identified 30 priorities within 5 categories that you see here. For example, under the category of treatment, priorities included questions about the optimal time to start ART, questions about ART regimens to use alongside TB treatment. Under the category of intensified case finding, there are questions about threshold levels of HIV and TB prevalence that might signal the need for more aggressive case detection strategies. In 2010, these research priorities were revisited and an updated set was developed, pointing to categories, to questions within 6 categories. And here they highlighted issues around TB screening strategies, infection control, INH preventive therapy, around identifying new tools, such as a rapid point-of-care diagnostic, or new drug regimens that could shorten TB treatment, and identifying priorities around integrating TB and HIV services at community and health sector levels. Now, the processes of defining the priorities that are reflected in that document reflected a systematic approach to reviewing the range of candidate priorities based on some defined set of criteria. And there have been a number of these efforts to develop these sort of systematized priority setting approaches over recent decades. The essential national health research approach focused on national level decisions. This was later augmented to focus on the management aspects of the process. An approach developed by the Child Health and Nutrition Research Initiative actually was what was the basis for the TB HIV priorities that I just showed you. On the so-called 3D combined approach matrix, which emphasizes the interplay between multiple criteria and multiple stakeholders. I don't really want to go into too much detail about these methods, but I'd say that they share a common objective, which is to try to provide a structured and step-by-step set of guidelines to help people navigate through the process of balancing competing criteria, accounting for values of stakeholders, and reconciling differences between decision makers in some fair and legitimate way. While there's a growing interest in these methods for multi-criteria decision making, I'll say that this is not an area of expertise for me. So I'd like to start to narrow a little bit in on one of the key elements of these frameworks, which is the specific evidence central to this process, and that is evidence on the health and economic effects of different choices. So often this evidence depends on simulation modeling to try to answer what-if questions about how new outcomes and costs might differ under different scenarios, for example, if new interventions are developed and deployed. So here's just an example from ongoing modeling work that I've been involved in with a terrific team at Harvard that includes Nick Menzies, Megan Murray, Ted Cohen, and others. In this case, I'm just going to show as an example some quite provisional results looking at what WHO has identified as a top research priority, which is to develop new drugs that could shorten the duration of TB treatment regimens. And so we've used dynamic models that are calibrated to reproduce TB epidemics in different settings. Here I'm showing you examples from Bangladesh and Kenya. And we can use these models then to simulate outcomes, such as TB mortality here, under different scenarios about what is available and what is done. And so in the case of new, shorter drug regimens, we find in these simulations a relatively modest potential impact of simply shortening drug regimens and introducing these into a status quo with no other changes. And basically the effect here is to simply raise cure rates by limiting the opportunity to default. We find there could be greater gains if we had new drugs and introduced these alongside better diagnostics for smear-negative TB. And you can see that the magnitude of the additional benefit is greater in a place like Kenya, where there's a lot of TB HIV, and that implies a lot of smear-negative disease. And we can also look at a more speculative scenario that asks what would be the gains we might see if we could leverage shorter regimens in order to try to facilitate expanding treatment coverage. And the reason that I think this what-if question is significant and interesting is that the gains are potentially quite large, and it forces us to ask the next question, which is what might it take for us to actually get there? And then so this is meant as a bit of a teaser for where I'm heading with all of this, which is a reminder that implementation questions and questions around delivery and health systems should never be too far out of our mind, whether we're thinking about priorities for existing or future interventions. And so let me move then from thinking about research priorities to thinking about priority setting for currently available strategies. And I'll focus in particular on the role of cost effectiveness as one of the key inputs into priority setting discussions. And so I want to begin with a simple observation, which is that every year there are literally hundreds of published cost effectiveness analyses in public health and medicine. And this is across all problems, and charted here are data from Peter Newman's group at Tufts that show the rise in the publication of CEA, cost effectiveness analyses, over time. So there's a huge volume of this research, but you're pretty hard-pressed to find too many examples, especially outside of rich countries, where this information appears to be explicitly or directly involved in policy formulation. And so the question that's behind the agenda that I want to talk about is why this contradiction. And I'll try to suggest three challenges that I think have contributed to this, and more importantly, to suggest some directions for the field in response. First, I want to set up two specific policy issues relating to HIV and TB that have gotten a lot of attention recently, and I'm sure are familiar to all of you. So as you all know, the last 3 years have been quite remarkable in terms of the degree of optimism that has really gripped the scientific and policy communities in HIV/AIDS. In June 2011, the cover of The Economist posed the end of AIDS as a question. By November of that year, it had turned into actual policy. November was this really remarkable month that was bookended by speeches by Secretary Clinton and President Obama declaring the beginning of the end of AIDS. And in between them, this rather sobering reality check from the Global Fund reminding us about ever-present resource constraints. Now, what got everybody so excited, as you all know, was the results from HPTN 052, which found overwhelming evidence that early ART could have major prevention benefits with a transmission reduction of about 96%. And so science that year declared HIV treatment as prevention to be the breakthrough of the year, you all recall. Now, as somebody who works across TB and HIV, as I know many of you also do, it's been hard to avoid feeling a little bit of deja vu as the HIV policy community has embraced this notion of HIV treatment as prevention. And that science cover reminded me of a similar declaration around TB about 15 years earlier when WHO hailed DOTS as the breakthrough, in this case, of the decade. And it's not just the PR around it, but also the strategies themselves that are really quite reminiscent. So as Paul Nunn at WHO had said at the time about DOTS, prevention lies in the cure. If you cure patients, you prevent them from transmitting the disease. So DOTS really is, in many ways, the prototype for treatment as prevention. But as you all know, since WHO endorsed DOTS, the reality has been that uptake has been slower than we had hoped. And I think there's increasing recognition that expansion of coverage doesn't just happen magically, that different strategies might be needed in settings of high HIV, which we're talking about here in the symposium, or drug resistance, which has also been mentioned, and that there's urgent need for new and better tools, but also attention to systems and delivery questions. Now, as it happens over the last couple of years, the TB community has also been excited about a new technology. Again, I'm sure that this is quite familiar to many of you, but the expert MTB RIF test has emerged recently and was initially touted as a potential game changer in TB control. Just as a reminder, the conventional approach to TB diagnosis using smear microscopy is slow to deliver results, detects only about half of pulmonary cases, and less than that when HIV is prevalent, whereas the new test is a simple cartridge-based PCR system, gives results in 2 hours, and does pretty well at identifying smear-negative patients that are missed by microscopy. So WHO moved quickly to embrace the new technology and called it the foundation for a revolution in TB diagnostics. And one of the early cost-effectiveness studies of EXPERT found that it would be quite attractive from a cost-effectiveness perspective with a ratio around $150 for every healthy year of life, which implies very, very high value for money using conventional benchmarks. So thinking about these examples from HIV and TB, as the global health world moves to translate new science into policies, I think questions about cost effectiveness are quite prominent. And I think these two cases do help us to illustrate some of the challenges that we need to confront as we think about priorities for TB and HIV. So coming back to this question that I began with, why is it hard to see where cost effectiveness has moved policies? And what I'd like to do then is to describe 3 problems that I think have contributed to this dilemma and suggest some directions to move the work forward. So the first problem, I think, is that many published cost-effectiveness analyses are just simply too good to be true. And so these are some examples from HIV prevention and treatment published now about a decade ago. And by typical benchmarks for cost effectiveness, which suggests that an intervention is good value for money if it buys a year of healthy life at less than GDP per capita, all of these interventions fit that bill. And in fact, some of them at $1 per disability-adjusted life year averted would be among the very best values in healthcare. The trouble is, as you all know, we've spent vast amounts of money over the last decade on HIV. And a great deal of this has been for prevention, even though the bulk of it indeed has been for treatment and care. So if the interventions that we've been buying were really giving us the enormous value for money that those cost-effectiveness results imply, I submit to you that we really should have seen a massive prevention impact, and yet this hasn't really materialized in many places. And so we can come back to these results and think about cost effectiveness and hypothesize about the reasons for this discrepancy. And I think it's on both sides of the cost effectiveness equation. We're probably overestimating effectiveness by extrapolating from small controlled trials. We're almost certainly underestimating costs, among other reasons, by assuming that people operate efficiently. And so here's the first agenda item, to try to understand why there's this disconnect between estimated cost effectiveness and what we see in the real world. And I think what this calls for is more ex post evaluation of cost effectiveness, evaluation of actual programs after the fact, to hold a mirror up to the more common model-based ex ante predictions. And so there is in global health rising momentum for impact evaluation, and I think we should build on this and assess both costs and health effects of real programs more than we're currently doing. The second problem, I think, is that cost effectiveness analyses often fail to focus on actionable decisions. So let me pause here and offer a brief aside. If you were to go and collect up all of the fact sheets and press releases and policy reports that come out in global health, and then had to guess what the single most common sentence that appears in these, what do you suppose that would be? Well, here's what I would guess. It's this sentence: we know what works. So the Safe Motherhood Initiative is famous for having this as its mantra over the last 20 years. Here's an example saying we know what works, and by the way, it's also cost effective. UNICEF knows what works in child and adolescent health. And again, we know how, but we need to act with renewed urgency. We know what works in malaria, and again, it's cost effective. And of course, in HIV/AIDS, Peter Piot tells us we know what works. Hillary Clinton reiterates we know the route we need to take. So I think all of these statements tend to follow this template. We know what works, but we're lacking something, and you can fill in the blank here. We're lacking money or political will or a proper sense of urgency. But you'd think from all of these statements that we're really in pretty good shape. The only problem is that I think most of these statements are actually wrong, or at least incomplete. So we do know a lot about what works clinically, what can be efficacious at an individual level, if you've got good adherence. We generally know much, much less about how to produce population-level benefits by delivering efficacious interventions at scale, with high uptake and with good provider and patient adherence. In other words, we know about promising interventions and technologies, but we don't know, or we know much less, about what delivery and scale-up strategies will be most effective and most cost-effective, particularly in settings where health systems are weak. And the problem is that a lot of cost-effectiveness analyses are located very close to the efficacious technologies and not close enough to the delivery strategies. And so often what you see in these analyses are actually more like outcomes. In the case that you maybe can read here, measles vaccination at 80% coverage, without realistically specifying or accounting for what are the policies and the operations that would actually be required to get us to these targets, nor an acknowledgement in many cases of the health system's constraints. And so what is needed, I think, is a real focus on strategies rather than technologies. In other words, a combination of a technology and a specific approach to deploying that technology and delivering it at some scale. So let's look at some of the policy analyses around HIV treatment as prevention in this light. Before HPTN 052, there was a lot of debate kicked off by the publication of this paper by Rubin Granich and colleagues in 2009, which called for a strategy of universal test and treat. There was a spectacular exhibit from this paper that you all may remember, suggesting that this strategy could lead quickly to virtual elimination of HIV transmission. And there was a companion analysis, I think equally striking, suggesting that universal test and treat would actually lead to a net decrease in costs within just a couple of years after the policy change. And I don't want to pick too much on this specific study because I think there's a general issue here, which is that most economic evaluations don't tend to address the concrete policies and operations that are needed in this case, to recruit people into testing and refer them into care and retain them in order to really get the potential benefits of ART as both treatment and prevention. So revisiting questions about the cost and cost effectiveness of scaling up ART, this is some work that Jeff Eaton and Nick Menzies and colleagues have led, a consortium of modelers looking systematically at results from different mathematical models of scaled up ART. And these are results for South Africa. In this chart, there's two sets of results. Each of the individual bars is a model, but the block on the left are strategies looking at changing eligibility criteria. On the right are strategies seeking to actually expand access. And what you can see is that on the left, there are some cost savings because this strategy involves moving individuals from pre-ART to ART and lowering the incremental costs. But you note particularly on the right that strategies involving scale-up of coverage should account for substantial costs due to expanding testing programs, and even those are probably underestimated in many of these models. So this is not a new observation. I think, again, you all are probably quite familiar with the so-called cascade of care. You can see in results from the US shown here that for 1 million people HIV infected, by the time you get them through diagnosis and linkage, retention in care, all the way to effective therapy, we're down to about 1/5 of those. And alongside this, there's been a range of operations research trying to seek ways to maximize successful movement through the cascade, and typically thinking about auxiliary interventions, mobile testing interventions to strengthen referral systems, and so on. But what's not yet happened is to develop a real marriage between decision analysis and implementation research. There seems to be a sequence in which people first do cost-effectiveness analysis to establish the potential for value, and then do implementation research to figure out a delivery strategy. But there are many, many choices to be made along the way with respect to implementation. And understanding the comparative effectiveness and cost effectiveness of these is really critical. And so here's the second agenda item. I think it's time for us really to get serious about integrating decision science with implementation science, to move from asking questions about the cost effectiveness of technologies and interventions to analyzing adoptable strategies that include explicit implementation and delivery components. And until that's done, I don't think we're giving policymakers with the evidence they need to make tough decisions. I'm aware of the time, but I want to highlight one other aspect, or just a couple of aspects briefly, using the example of expert TB test. And these are analyses, again, that Nick Menzies has been leading in our group, looking at various expert scale-up scenarios in countries to try to examine potential benefits and cost effectiveness. And one of the things this has taught us is that people really like simple stories, even though the world is complex. So cost effectiveness analysis by design asks a somewhat simplified question. How would you allocate resources if your goal were to maximize health under a single budget constraint? But we still, I think, need to avoid the trap of oversimplifying. So an example here with regard to expert is that one of the big benefits of expert is that it better identifies smear-negative TB, which is very common when there's HIV co-infection. And so a consequence of improving diagnosis of TB among HIV-positive patients is that more of them will survive and be successfully treated for HIV infection, which is a good thing for them, but also relatively expensive. Prior cost-effectiveness analyses on expert have given credit to the TB test for this survivorship gain without actually accounting for the costs of the ART. And Nick's model takes a much more detailed look at this. And you can see in this chart that thinking about the overall added costs of expert, the biggest component by far is the extra cost shown in blue of treating HIV. And so when we submitted this paper to the journals, we thought, well, this is one of the really interesting and important findings. And we actually encountered a huge amount of resistance in the reviewers and the editors about whether or not we should actually count these ART costs. And to us, it was obvious that we should, and we eventually prevailed on that. But we were actually quite surprised to find that we had to make this case. Some more recent work that I'll describe more briefly. We've been looking at various expert scale-up strategies in a wider range of countries. And I think this makes clear the distinction that I made earlier between expert as a new technology versus the actual strategies that are used to deploy it. So here, taking Kenya as an example and looking at TB mortality, we can start with a continuation of the status quo based on smear microscopy with limited availability of culture. If expert is deployed only where culture is currently being used, then the benefits shown here are essentially nil. Only if expert is disseminated where smear is being used but culture isn't does it make a significant impact. And again, gains could be especially great if we could identify effective strategies to extend coverage of expert beyond the current reach of smear. The important point here is that expert, the technology, doesn't inherently have an associated cost effectiveness, but specific strategies for deploying expert do. And they will surely vary over a huge range depending on the details of them. And just a final example here, this one hot off the presses as of yesterday, illustrates that it's also important to have a good understanding of what the new strategy will displace. There was a recent trial of expert versus microscopy in Southern Africa that noted that in HIV endemic settings, clinicians often will initiate empiric therapy based on clinical symptoms or X-ray or failure to respond to broad-spectrum antibiotics. And so we used our model to examine how this might impact on the estimated health benefits of expert versus the status quo, and indeed find that compared to an assumption that providers adhere strictly to results from smear microscopy here, if you account for a lot of empiric therapy, as you would expect, the benefits of expert are dramatically attenuated. And this clearly could have profound implications for conclusions about impact and cost effectiveness. And so I think all of these examples point to the clear related third agenda item, which is that priority setting and cost effectiveness need to be conducted with a very clear health systems lens, which accounts explicitly for all of the relevant costs, outcomes, and constraints that pertain to a particular implementation approach and in a particular context. And that's what I wanted to talk about today. As far as the landscape and the audience go, I think we all can observe that in this country, resistance to setting priorities and to talking about cost effectiveness or the dreaded rationing is very strong and entrenched. Arguably, in resource-poor settings, the resistance is much less strong and the need is that much greater. And so I think there really is an opportunity to provide information that can be useful to decision makers struggling with very hard decisions in the face of very strict resource constraints. And the challenge, as I've described it today, is to try to bring the research that we do in priority setting into better alignment with the need by increasing the focus on ex post evaluation and by moving from asking about what can work under optimal circumstances to asking about what does work and really can work in real world programming. So I hope we'll take on this challenge and really seize this opportunity to produce information that can be, I think, much more useful to global health policy. Thank you very much.
Great. Thank you very much, Josh. Very stimulating and sets the stage for a great day. So, questions?
So, Josh, I wonder, one of the important points you bring up is, one of the important points you bring up is that a much of, is something that you've modeled there, is that when you look at early studies of cost effectiveness in some of these interventions, when that intervention is being placed into settings where it's being investigated, which is generally places where good technology is already available, they're not going to look good. So what you would predict is that the early studies of cost effectiveness, of really measured cost effectiveness of expert, are going to be kind of lousy. They're not going to be any better than what they're replacing, because the places where they're being put in already have culture. I think that's an important point to bring up because it unfairly penalizes these new technologies.
Yeah, thanks for that. And I think there are certainly reasons to think that that when you start, as most of the cost-effectiveness analyses around expert have done with a place like South Africa, as you say, if you're accounting correctly for what's being done, that actually might be a setting in which the expected impact is relatively modest. You probably do expect that there's a greater gain to be had, for example, where there's not much culture being done. I think that's true, and I would, in general, say that we have to be very, very cautious about extrapolating from South Africa. We're currently in the process of trying to look at expert in a much broader array of settings. That said, I would say that there are many, many factors that lead cost-effectiveness analyses typically to be overly optimistic for some of the reasons that I've explained. So I think we really do need to do a better job in the field of cost-effectiveness of really accounting for what's happening on the ground. And in some cases, I think that can lead things to look more attractive, but in other cases, I think much less attractive. And I'd say, on balance, probably most cost-effectiveness studies are overly optimistic, and a lot of that bias, I think, comes from the costing side, where we're really failing to account for some of the resources needed, especially around the delivery and implementation issues. But I think the point that you make is one that I agree with.
Dan, let's just...
Yeah, you showed us that if you incorporate the cost of HIV therapy as part of the programmatic costs for detecting more seronegative cases of tuberculosis, that cost go up, but you didn't show us the impact on the cost effectiveness of the therapy. I mean, clearly those individuals need antiretroviral therapy. If you're identifying more people who need therapy and if the therapy itself is cost effective, it's not clear how you eventually come up with a cost ineffective approach.
Yeah, well, thanks for the question. So, in fact, in that analysis, even accounting for the costs of ART, as you say, because ART itself is cost effective, we found in that analysis that expert also was cost effective. The important thing to note is that our estimate of cost effectiveness was considerably higher than previous estimates that didn't account for the ART, because the ART costs are quite high, and in relative terms, while ART is certainly cost effective, it's not $1 or $2 or even $10 per healthy life year. It's probably 100, 150. So yeah, thanks for giving me the chance to clarify. It doesn't make expert look cost ineffective, but produces an order of magnitude difference in how cost-effective expert looks. And in the last example that I showed, where you account for empiric therapy and the status quo, that goes up again by a factor of 2. And so I think what I'm suggesting here is that some of the earlier results were too good to be true and incredibly attractive cost-effectiveness ratios. Expert likely is cost-effective in many settings, under many circumstances, probably not to the degree that some of the earliest studies suggest.
Okay.
Josh, on the same point, I think there's no end to the things you can tag on for cost or benefits. One of them, I think, we talked about yesterday, was the use of expert to detect unsuspected tuberculosis in the hospital, in institutional unsuspected drug resistance, and the opportunity to interrupt transmission. So if you're going to add on ART cost, one should also deal with the transmission prevented and the cost savings there, but then there's cost implementing, rapid turnaround time to make all this work. So it kind of goes on and on. I don't know if you've dealt with prevention in that analysis.
Yeah, thanks, Ed. I agree that that this can be extended, but I'm detecting that you find that discouraging, and I think it's just part of trying to be realistic. I think the other thing that comes out in the point that you make is that there are a range of different not only different algorithms within which you can deploy expert for, say, diagnosis at a health center, but other applications for expert, say, in a hospital setting. And so again, for me, that just underscores the point that the technology itself doesn't have an inherent cost effectiveness. You really need to think about where it's being used, within what algorithm, in what type of setting. And so I agree with that point. And I think if we're really going to try to say something that's useful for a decision maker, we can't speak in the abstract of this technology being cost effective. I think we really do need to be very explicit about how it's being used.
Okay, 2 more questions, maybe 1 year and
I'd like to comment on cost effectiveness of diagnostics, because I think that the critical moment is whether we can act upon information that you obtain using diagnostics. So for example, if at no cost you would obtain information about whole genome sequencing of individual isolates from individual patient and would be able to determine optimal drug combination that is needed to treat this patient, you would still not be able to deliver it because the drugs are not available. Would you be saying that this is not cost efficient a strategy and we should not really try to achieve something like that?
Yeah, I mean, I think in some cases when, and this comes at the distinction between R&D for new technologies versus cost effectiveness of strategies for deployment. I think in some cases you can imagine that by developing the technologies, we give a prompt to actually go and solve the implementation problems. If we have an effective technology, often that will induce us to then address the questions about delivery or address the questions of supply chain or pricing that maybe affects the availability of drugs. So I wouldn't suggest that we should use the cost effectiveness information as a way to discourage innovation. And I think certainly the example that you give is compelling. But I think when we're asking, particularly around strategies for deploying current interventions, it's not enough to ask that question in an abstract way because it really does depend on some of the things that you mentioned. So having diagnostics isn't going to produce the health benefits if you don't have the wherewithal to then act on what the diagnosis tells you. And I think that basic principle really should be reflected when we're thinking about choice between how we can spend scarce dollars in implementing programs on the ground. So I think it's not meant to preclude investment in innovation, and it's not meant to suggest that we can't take the development of innovative technologies as an impetus to then address the implementation issues. But I think when we're asking questions about policy for decisions that need to be made right now, we really need to be doing this in a realistic way that reflects the realities on the ground, and that doesn't tend to happen in the field.
Jerry Allen from Boston University. Thank you. I agree with everything that you said, I think. I want to just tell you about an observation. So I was in Uganda about a month ago, and I went out to a very rural site, Tororo, 5-hour drive from Kampala. Roads weren't great. To a health center 4, where they see patients who are TB suspects, and there's a fair amount of HIV in the community. And the algorithm is if someone is smear negative, the sputum is taken by a driver, and a real-time expert is performed at a central laboratory. Results come back, and that's used to decide to treat or not to treat. And Moses Jalobo, who's been responsible nationally for developing the laboratory infrastructure in Uganda, has decided in that country to have one central laboratory throughout the country to do culture and DST and to put experts in peripheral areas. So there are ways this can really transform availability of diagnostics, but I totally agree with your other comments.
Yeah, thank you for that comment. I think it's a great example of how we really can use this as a framework to think about health systems questions like that one. Where do you locate the central lab? How do you organize peripheral health centers? What's your strategy for deploying expert outside of the labs, or maybe in other strategies that involve mobile clinics, for example? So I think it's a great example that I think for me really underscores this idea of thinking about strategies and the huge appetite that I think is out there for decision makers to actually have some information about strategic choice like that. So thanks very much for the comment.
Josh, could I ask you one final question? So you started by saying the Rethinking AIDS effort, the Vice Chancellor of Ghana was involved. How much do you think in these priority setting exercises is there engagement by scientists or implementers from the countries where the problems actually exist? And what capacity is there for sort of bringing these implementation science and decision sciences together in those settings?
Yeah, it's a great question. I mean, I think the short answer is that there's not enough of that. An interesting side note about the Rethink HIV exercise is that not only did they elicit rankings from the so-called Nobel laureate panel, but they also elicited rankings from other groups, including a convening of members of African civil society organizations. Perhaps you'd be interested to know, but not surprised, that the rankings were different. And I think that is telling. And specific examples of the differences were more interest in, for example, training cadres of community health workers, more interest in sort of augmenting the testing facilities. And so I think your point is an absolutely important one, which is that in some sense there's a stark caricature that you could draw about the difference between consulting Nobel laureates in the ivory tower versus consulting people on the ground. And I think the empirical point that's important is that you can get very different results. And so I think there's not enough of that consultation, and I agree with what I know is your point of view, that I think we should think about how the field can engage more with people who really are directly stakeholders in settings.
Great. Well, thank you very much.